Motor cognitive dual task training for Parkinson's disease is rapidly growing in popularity with a very strong social media presence and widespread global implementation. But is this implementation based on current evidence or on professional expertise? The reality is that most professionals already integrating dual task training into their practice, but the lack of evidence is making them count on expertise and experimenting various methods until they find the most successful one. Now, this gap between the expertise, the evidence, its dissemination, and its implementation into practice will probably need several courses of action, and this thought-provoking initiative is one of those actions. Dual task interference or deficits are an important problem in aging and in several neurologic diseases, and in particular in Parkinson's disease. Identifying these deficits may provide better insight into an individual's ability to function in everyday life. So early assessment and treatment will become key components of Parkinson's disease management very soon. Most daily life activities require people to perform one or more tasks at once. There are, however, some difficulties in understanding what is considered a dual task. For example, would you consider walking and talking a dual task? Is walking and talking on the telephone a dual task? What about walking while simply holding your phone in your hand? Holding your phone seems like a task that might not require as much attention, so if it is or isn't an additional task is still unclear. Typically, when tasks are performed regularly and become routine, they will not require as much attention, unless of course you have Parkinson's, where changes in the basal ganglia negatively impact these overlearned movements. The dysfunction of the dopaminergic pathways of the basal ganglia may lead to reduced movement or domesticity and the need for increased reliance on cognitive resources to control movements. You can also have dysfunction of the non-dopaminergic pathways that might affect both movement and cognition and also contribute to this dual task movement deficits that we see in Parkinson's disease. Essentially, we often hear the cruise control is becoming impaired, and this makes cognitive attention necessary to control daily life activities. So you can see several changes. For example, walking indoors with additional cognitive or motor tasks simultaneously will ultimately be more challenging. Walking and talking outdoors progressively also becomes challenging. Walking and quickly stopping to take a picture on your phone. Walking and talking on the phone and deciding when to cross the street. Driving and drinking and talking or even listening to someone. Trying to eat and drink and talk and laugh, preferably without making a mess or even worse, having a choking incident. Easily distracted while eating and watching television at the same time. Overall, all these activities will become progressively challenging as the disease progresses. Dual task difficulties are already seen at diagnosis and will progress throughout the disease. In early stages, people often don't report having difficulty walking and talking at the same time. But what we see is that they are not perceiving that a leg is starting to drag or that there is a reduction in their arm swing when they are walking and talking. This interference may not be easily detected during simply walking due to satisfactory compensation mechanisms. In fact, people with Parkinson have many difficulties in perceiving them. There can be trips and stumbles, but there is a tendency to relate these to environmental hazards, to poor footwear, imperfections in the pavement, or even previous injuries. Usually it's more the family members that will identify better these dual task related difficulties, saying things like, "Oh, he lowers his cup and he almost spills the coffee when speaking to me," or "He can't seem to answer me while walking and carrying a glass of water," or even "His posture or his tremor or his dyskinesia gets worse when he's talking while standing." In the middle and later stages, you might see things like talking starts to get faster when walking at the same time. So you have speech volume and the accuracy and even the word choice have been shown to have changes under dual task. As disease progresses, more hesitations start happening and people feel the need to temporarily interrupt or stop an activity to be able to talk. A known phenomenon as the stops walking when talking. And you can see this in this video very often. And here you have 3 people with Parkinson, one that has 5 years of Parkinson disease, another of 2, and another of 20 years. Objectively, we have a considerable amount of research showing that walking under dual task will lead to reduced speed, reduced step length, and increased gait variability. There's also greater variability in cognitive performance under dual tasking. As the disease progresses, more hesitations start happening, freezing of gait episodes may begin, first when turning, then when walking forward, especially when needing to make quick decisions. We can easily see how all this leads to balance difficulties and increased risk for falls. And this is why this issue is so critical. Now let's see how Barbara, that's 68 years old and with 3 years of Parkinson's disease, how she perceives her difficulties relating to dual task and balance.
Yeah, I could be standing still and all of a sudden I just lose my balance. I can usually catch myself. I never usually fall. I can't remember an incident where I fell, but I lose my balance. I have to, it's real noticeable.
So you would say that you lose your balance backwards, like taking a few steps backwards?
Yeah.
Can you recall a situation where this happens, and if you associate it to the fact that maybe someone is talking to you or you're doing an additional task?
No. I could be standing around listening to somebody, and I would lose my balance.
So someone talking to you and you listening actively to them, right?
Yes.
So that is considered doing something else. So it's like your attention is focusing on what that person is saying, and that on its own is studied to influence balance.
Okay.
So if you're listening to someone, if you are talking, do you think the same thing happens?
Yes, definitely.
It might be hard to distinguish which one would be more difficult.
Probably talking, if I'm talking to somebody, although I'm a really good listener.
How about other daily activities? Well, people tend to complain about feeling progressively slower, having difficulties in getting out of a chair, falling into the chair when sitting down, getting in and out of bed. All these activities are particularly worse under distracting factors. And you might see changes in speed of that activity, changes in the posture, losing balance during all these activities. In this video, you can see the gentleman struggles to get out and he almost falls when he turns. He is 86 years old, Parkinson's disease for 5 years. And what we see is the automatic response of postural control required here, which is to pivot his foot first, has been lost and will require cognitive attention. So now any action that's preceding getting up clearly will influence his performance. Getting up to get to a phone or answer the door, or even being too busy thinking his own thoughts will be enough to place him at risk. At risk because cognitive attention is needed to control the turning and maintain the balance. So improving dual task performance in Parkinson is a growing area of interest, but what are the non-pharmacological solutions that we have at this moment for this problem? We can have, on one hand, cognitive training, commonly applied by neuropsychologists, occupational therapists, or speech therapists, depending on which country you live in. We can have the physical training, as it has been proven benefits in both physical and cognitive outcomes. But by combining these interventions, we have a new potential method of treatment, dual task training. Dual or multitask is commonly defined as performing activities that require you to simultaneously perform 2 or more tasks, where one task is the primary task, for example, walking, and the other is a secondary task, for example, talking or listening to someone. In the gym, it can take on different forms. It can include adding 2 cognitive tasks or 2 motor tasks, or the combination of a cognitive and a motor task. Both must be performed independently. and both must be able to be measured separately and also have distinctive goals. Let's see an example of a training session incorporating dual task exercises with 3 people with Parkinson, relatively young and high functioning, and that are being challenged to keep walking while taking certain actions according to their quick interpretation of an auditory stimulus, in this case random numbers. So if they hear a 5, they lift up both their hands. If it's an even number, they take a step forward. If it's an odd number, they take a step back. And we later increase the complexity by running forward every time they hear the even number.
5, 9, 8, 7, 3, 5, 6, 5, 7, 9, 5, 1, 6, 5, 9, 8.
Despite preliminary evidence in support for the value of this motor cognitive training for Parkinson's disease, there are still no clinical guidelines on how to apply it, and healthcare professionals struggle to access the evidence for this type of motor cognitive training, as well as to access knowledge and guidance on when, how, and to whom we should be applying it, in what stages, when do we use it, should we exclude any particular situation, are there any risks, how do we apply it in the session, in the program, where can I get new ideas? These are all questions that people are reflecting on. The medical and research society are basically concerned about one question: can you safely apply it now with limited evidence and lack of expertise? Notably, there is an optimal level of disease-specific expertise necessary to integrate dual task practice, particularly with respect to being able to safely integrate exercise without putting patients at risk of falling or any other adverse issues. By prematurely applying this type of exercise approach to people with Parkinson, health or exercise professionals with the lack of professional expertise may 1. Increase the risk of falls and other adverse events, 2. Deliver unnecessary procedures, 3. Include patients with less favorable profiles in this type of practice, 4. Foster unrealistic expectations. This will compromise long-term benefits and adherence. And you can see how all this may lead to less confidence in practice and with negative consequences on research and referrals. Ultimately, dual task training can't realistically be avoided in daily life. So it's reasonable to prepare people for it, and as soon as possible. For more than 20 years, we have seen research on the effects of cognition over movement, and more recently, the effects of movement over cognition. The extent of these effects appears to be different and depending on the individual, the task, and the environment, but the relative contribution of each factor is still not very well known. The topic of dual task training has been receiving increasing research interest since 2008, and accumulating evidence in Parkinson is coming out. There were some concerns and conflicting early recommendations in 2004 that people with Parkinson should avoid performing dual tasks. But in 2008, we had the first pilot study from Australia showing feasibility and benefits of such training over gait parameters. It was later in 2014 in the European Physiotherapy Guidelines that we highlighted clear recommendations to integrate such practice, particularly for gait training. There are now several studies coming out, but I'll suggest at least 2 references that should be read, which is the High Balance program from Sweden, focusing on balance and gait under dual task, and the Duality study from Belgium, comparing different types of modes of training.
I think I used to think that dual task training could only be applied, or should only be applied, for people that were doing pretty well with a task, or already had it kind of down pat. I think what I've learned now is that you can apply a dual task to just increase the fun kind of level, or to help the patient connect with a new movement strategy more and kind of help imprint that in their movements better. So I would say I apply it now with patients at any level of ability, because I think I can titrate the activity, the complexity, the fun. I always felt like I was running out of ideas and not really sure how to challenge my patients appropriately, to focus on their movement while thinking and making decisions, and just something different to keep the patients engaged and interested. I think I'm now able to apply dual task training to almost all of my patients because I think I can titrate the challenge for them appropriately. I'm able to keep it fun, keep it engaging, keep it different, and do something that really speaks to that particular patient using these strategies, no matter what their cognitive level is and really no matter what their fitness level is. There are so many ways of changing what the activity is, and I've gotten to be able to learn how to change that myself to be really appropriate for the patient.
Deciding when or to whom we should be applying this type of practice is still based on best clinical judgment and clinicians' preferences. But from the duality study, we are guided now to start as early as possible. In the study, the patients in early stages of the disease benefit most from the dual task training. So people who had a slower dual task gait velocity and good cognitive functioning at baseline had the larger improvements in the dual task gait velocity outcomes after both types of training. Let's see now 3 different videos of different stages and the type of exercises that we could apply for early stages, for middle stages, and for later stages.
Ease, yes. Ease. Wow. Oh, straight and rush. Straight and rush. Wow.
Number 1,
3. 2. 1.
Overall, we are guided to start as early as possible. People with a greater disease severity are less likely to improve, but it may still be feasible. Use it when there is a clear presence of dual task impairment, either verbalized by the patient, by the family, or identified by the therapist. And we want to objectively improve the patient's capacity to dual task in real life by mimicking activities that occur in his life and where he's under dual task situation and he's having trouble. We know that more significant transfer effects will occur in conditions that are trained. So the closer the activity is to how it happens in real life, the greater our chances of improving it outside the clinic. So another reason to use dual task training is when we want to enhance the motivation. By making training programs that are more engaging and fun, we can enhance ongoing motivation. But this will also increase our chances of enhancing learning. Even in severe situations with weak potential for transfer, If it doesn't transfer, at least it helps us maintain patients engaged in the exercise. In this video, we are training the patient to give priority to changing directions and turning safely, using as a distracting factor punching the balls. Later, we will increase the complexity by giving each ball a secondary cognitive task.
Please, and towards and keys. Oh, the set. P. The set. P.
Dual task training should be like rafting. You know, navigating a river of options. Things are changing all the time. You go through sections that are more difficult or and less difficult, keeping a balance between being bored and being frustrated. And all this has to be part of a nice, challenging but fun experience.